Hello students, today we will be discussing on ectopic pregnancy, that is mainly the mode of termination and the clinical features involved in ectopic pregnancy. Ectopic pregnancy occurs when a fertilized egg implants outside the uterine cavity, most commonly in the fallopian tube. This condition is a medical emergency and requires a prompt diagnosis and treatment to prevent a serious complications such as rupture and hemorrhage. Mode of termination and clinical features of ectopic pregnancy. Mode of termination: because of the unfavorable environment, early interruption of pregnancy is inevitable within 6 to 8 weeks. The modes of termination are as follows. The first one, tubal mole. The formation of the tubal mole is like that formed in a uterine pregnancy. The fate of mole is either a complete absorption, expulsion through the abdominal ostium as tubal abortion with a variable amount of internal hemorrhage, or the encysted blood so collected in the pouch of Douglas is called as pelvic hematocele. So these are the ways how the tubal mole, that is the termination of the ectopic pregnancy, happens in the form of tubal mole. So it may be a complete absorption, expulsion through the abdominal ostium, that is through the fimbriae. You have the fallopian tube and the end part is the fimbriae, so that part we call it as an abdominal ostium. It's an opening in the abdomen, so you can see that expulsion through the abdominal ostium as a tubal abortion with a variable amount of internal hemorrhage, and the so collected blood, that is encysted blood in the pouch of Douglas, is called as pelvic hematocele. Next way of termination is tubal abortion. This is the common mode of termination if implantation occurs in the ampulla or in the infundibulum. Prior to abortion, the ovum may be converted into mole, or else a living ovum is aborted as tubal abortion. Next one is tubal rupture. The tubal rupture is predominantly common in isthmic and in interstitial part of the fallopian tube. Isthmic rupture usually occurs at 6 to 8 weeks, the ampullary one at 8 to 12 weeks, and the interstitial one, that is any implantation in the interstitial part of the fallopian tube, may extend up to the 4 months. So the tubal rupture can happen in any part of the fallopian tube, which is one of the obstetrical emergency. Depending upon the site of the rupture. So in tubal rupture, it may be an intraperitoneal rupture or extraperitoneal rupture. Intraperitoneal rupture, this type of rupture is common. The rent is situated on the roof or sides of the tube and the bleeding is intraperitoneal. Whereas in case of extraperitoneal rupture, which is also called as a intraligamentary, this type of rupture is rare and occurs when the rent lies on the floor of the tube where the broad ligament is attached. It is commonly met in isthmic implantation. So that is called as intraperitoneal rupture as well as extraperitoneal rupture. If the rent or the opening, which we say because of the rupture, it forms a rent. If the rent is situated on the roof or on the side of the fallopian tube, it is said as an intraperitoneal rupture. And if the rent is at the lower part, that is near to the broad ligament, we call it as extraperitoneal rupture or intraligamentary. Moving on to the next slide, so we will have a discussion on the abdominal pregnancy. So what is this abdominal pregnancy? Secondary abdominal pregnancy. There are certain prerequisites for the continuation of the fetal growth outside the tube. So what are those prerequisites so that the pregnancy will be a abdominal pregnancy? The fetal will grow outside the tube. So there are certain prerequisites. So perforation of the tubal wall should be a slow process. So in that case, there are chances of abdominal pregnancy. Amnion must be intact. Placental chorion should escape injury from the rupture. Herniation of the amniotic sac with the living ovum and the placenta should occur through the rent. The placenta gets attached to the neighboring structure and a new vascular connection should be re-established. The fibrin is deposited over the exposed amnion to constitute a secondary amniotic sac. Intestine, omentum and adjacent structures get adherent to the secondary sac. So these are the various prerequisites which has to be completed in order to go to a stage of secondary abdominal pregnancy. Moving on to the next one, that is the secondary broad ligament pregnancy. In secondary broad ligament pregnancy, the pregnancy may continue in the same process as in the abdominal pregnancy. The growth of the pregnancy is limited between the two layers of the peritoneum, which may be stripped off the pelvic floor. Occasionally, the sac may rupture secondarily at a later period and the fetus is extruded into the peritoneal cavity with the placenta attached in its original position, forming a secondary abdominal pregnancy. So this is the way how from the secondary broad ligament pregnancy it may also lead to a secondary abdominal pregnancy, whereas the placenta will be attached in its original position. Moving on to the next, that is what is the fate, what happens in the secondary abdominal pregnancy. So the fate of secondary abdominal pregnancy: death of the ovum with the complete absorption. Catastrophe may occur due to the separation of the placenta leading to the death of the ovum with massive intraperitoneal hemorrhage. The gestation sac may be infected and a fistulous communication with the intestine, bladder, vagina or through the umbilicus may occur. The fetus dies and undergoes mummification or adipocele formation or becomes calcified to form a lithopedion. Rarely it may continue to term due to environment, scanty liquor and chronic placental insufficiency. The fetal malformation and deformation are more likely to occur. The fate of the broad ligament pregnancy. Broad ligament ectopic pregnancy are rare and often diagnosed intraoperatively. Several case report document successful treatment of this pregnancy with surgery. So you can see that the fate of the broad ligament pregnancy is it's one of the emergency conditions, as well as you can see that the babies are not properly formed, the fetus is not properly formed in case of broad ligament pregnancy, and that is the fate of this broad ligament pregnancy, where it is difficult to rule out also, as well as you can see the abnormal fetus which has been developed in case of this condition in broad ligament pregnancy. Moving on to the clinical features of ectopic pregnancy. Clinically, three distinct types are described, that is acute, unruptured, subacute, chronic or old ectopic. Clinical features of ectopic pregnancy. Acute ectopic. Acute ectopic is fortunately less common, 30%, and it is associated with tubal rupture or tubal abortion with massive intraperitoneal hemorrhage. So, this is the symptoms which you can see in case of acute ectopic, which leads to tubal rupture or tubal abortion. Patient profile. The incidence is maximum between the age of 20 to 30 years, being the maximum period of fertility. The prevalence is mostly limited to nulliparity or following long period of infertility. Mode of onset. The onset is acute. The patient, however, has got persistent unilateral uneasiness in about one-third of cases before the acute symptoms appear. The symptoms includes the classical triad symptoms of disturbed tubal pregnancy are amenorrhea, that is 75%, abdominal pain 100%, appearance of vaginal bleeding 70%. Symptoms include a short period of amenorrhea of 6 to 8 weeks or a delayed period or slight spotting on the expected date of period is usually present. Abdominal pain. Abdominal pain is the most constant feature of the triad. The pain is acute, agonizing or colicky in nature. In between the colicky pains, the patient remains in agony, a feature which differentiates it from intestinal colic. Initially, the pain is located in the lower abdomen on one side but gradually spreads all over the abdomen. The causes of pain are distension of the tube by blood, colic of the tubal muscle, peritoneal irritation. The pain may be referred to as shoulder due to diaphragmatic irritation. Next one, the vaginal bleeding. The bleeding is light, sanguineous or dark colored and usually continuous. Expulsion of decidual cast may be there, that is for 5%. Next one, feeling of nausea, vomiting, fainting attacks, even to the extent of syncope may be present. The syncopal attack is peculiar to ectopic and is probably due to reflex vasomotor disturbance caused by irritation of the peritoneum by the blood. On examination, general look is diagnostic of acute ectopic. The patient lies quiet and conscious, perspires and looks blanched. Pallor is usually severe and depends on the amount of internal hemorrhage and is significantly out of proportion to visible vaginal bleeding if any. Features of shock are evidenced by the rapid and feeble pulse, fall of the blood pressure and cold and clammy extremities. Abdominal examination reveals the abdomen is tense, timid and tender. The tenderness is mostly limited to the lower abdomen. No mass is usually felt. Shifting dullness may be elicited. Gut may be distended. Bimanual examination. Bimanual examination may precipitate more intraperitoneal bleeding due to manipulation. The findings are vaginal mucosa, which looks blanched white. Uterus seems normal in size or slightly bulky. Extreme tenderness on fornix palpation or on movement of the cervix. No mass is usually felt through the fornix. The uterus float as if in water. So these are the symptoms which you can see in case of acute ectopic. Moving on to the next one, that is unruptured tubal ectopic. Here, the high degree of suspicion and an ectopic conscious clinician can only diagnose the entity and its pre-rupture state. It is most often diagnosed accidentally during laparoscopy or laparotomy. The physician should include ectopic pregnancy in the differential diagnosis when a sexually active female has abnormal bleeding or abdominal pain. The symptoms, which include presence of delayed period or spotting with features suggestive of pregnancy, uneasiness on one side of the flank which is continuous or at times colicky in nature. The signs which you can see in bimanual examination. Uterus is slightly smaller than the period of amenorrhea, showing evidence of early pregnancy. A pulsatile, small, well circumcised tender mass may be felt through one fornix separated from the uterus. The investigations which you can perform is with the advent of transvaginal sonography, highly sensitive radioimmunoassay of beta HCG and laparoscopy. More ectopics are now diagnosed in unruptured states. Moving on to the next type, that is chronic or old ectopic. Onset. The onset is insidious. The patient had a previous attack of acute pain from which she had recovered, or she has a chronic features from the beginning. The symptoms which includes, in case of chronic or old ectopic, amenorrhea of short period of 6 to 8 weeks is usually present. Lower abdominal pain is present with varying degree. It starts as an acute one and gradually becomes dull or colicky in nature. Vaginal bleeding appears sooner or later following the pain. It is scanty, sanguineous or dark colored and continuous in nature. Other symptoms, they may be a features of bladder irritation, dysuria, frequency or even retention of urine. Rectal tenesmus may appear especially following the infected hematocele. Rise of temperature may be due to infection or due to absorption of the products of degenerated blood accumulated in the abdomen. On examination, the patient looks ill. Varying degree of pallor is present which is not proportionate to the continued vaginal bleeding. Persistent high pulse rate, features of shock are absent. Temperature may be slightly elevated to 38 degrees Celsius. Abdominal examination. The abdominal examination shows tenderness and muscle guard on the lower abdomen, especially on the affected site, is a striking feature. A mass in the lower abdomen may be felt which is irregular and tender. Cullen sign, that is a dark bluish discoloration surrounding the umbilicus, if found, is suggestive of intraperitoneal hemorrhage. Next, moving on to bimanual examination. Bimanual examination is painful and it reveals vaginal mucosa which is pale, uterus seems to be normal in size or bulky, extreme tenderness and movement of the cervix. An ill-defined, boggy and extremely tender mass is felt through the posterolateral fornix extending to the pouch of Douglas. The mass may push the uterus to the opposite side. Rectal examination corroborate the pelvic findings, means it confirms. Corroborate means it confirms. Examination under anesthesia, that is EUA, examination under anesthesia is helpful to evaluate the pelvic findings, but accident tubal rupture may be provoked during the manipulation. So we have come to the end of this part 2 on ectopic pregnancy. Effective management strategies, which involves the early diagnosis through clinical evaluation, ultrasonography and laboratory testing, including the serum beta HCG levels and also the clinical features which are involved in the acute ectopic, the unruptured ectopic and the old ectopic is very essential. The nurses has to recognize the symptoms, the signs and symptoms which are associated with these three types of ectopic pregnancy for a proper treatment and the management. So we'll be dealing with a treatment and the management of ectopic pregnancy in the part 3 of ectopic pregnancy. Thank you for listening to this presentation on ectopic pregnancy. I hope this was informative for you, and if you have any questions you can put it in a comment section. Thank you.